record. Okay. So extended spectrum penicillin, we have aminopenicillin, which includes ampicillin and amoxicillin, two important clinically used penicillins. And next is uridopenicillin. In that uridopenicillin, we have piperacillin. Okay. These are the important extended spectrum penicillins. Piperacillin, ticarcillin is there. So the extended spectrum penicillin covers the same thing: gram-positive cocci, gram-negative cocci, gram-positive bacilli. Gram-negative bacilli is additionally covered. So apart from the routine things which I told you, skin and soft tissues, bone and joint infection, infective endocarditis, and all these things, we can give it for urinary tract infection, intra-abdominal infection, bloodstream infection, hospital-acquired infections also. Correct?
Well, can you repeat that line again? What you said now?
I told you penicillin, the routine spectrum is gram-positive cocci, gram-negative cocci, gram-positive bacilli, spirochetes,
and the spirochetes and some anaerobes.
Plus, if you are adding gram-negative bacilli, apart from this spectrum, skin and soft tissue, bone and joint infections, skin and soft tissue infection, we can additionally give it for intra-abdominal and UTI.
Okay. Yeah, got it.
Now tell me, penicillin, can it be used for UTI? Plain penicillin.
No.
Cloxacillin, can it be used for UTI?
No.
Can ampicillin be used?
Yes.
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 Because it covers gram-negative bacilli.
Yeah.
Now tell me, can piperacillin be used for UTI?
Yes.
Right. You understood? No. This is how you decide.
Got it.
So apart from the routine things, it covers gram-negative bacilli like E. coli, H. influenza, Salmonella, Protea, Shigella, etc. Right. That's all. Now, there's a problem. Even though it covers gram-negative bacilli, most of these are beta-lactamase sensitive, similar to penicillin. So to overcome penicillinase resistance, Staphylococcus aureus in penicillin, we created another group called as methicillin group. But this ampicillin, amoxicillin, piperacillin, and ticarcillin, they are very good antibiotics, but they are highly sensitive to beta-lactamase. So which are the organisms producing beta-lactamase? Same thing, Staph aureus. And I told you the gram-negative bacillus also produces beta-lactamase, ESBL, extended spectrum beta-lactamase. So how to overcome that? Because it's a very important group. So to make this even more effective, we are adding another group of drugs which is called as beta-lactamase inhibitor. So ampicillin, amoxicillin, piperacillin, they are beta-lactams. Plus, we are going to give another drug which is called as beta-lactamase inhibitor. Now, I think you will understand what is the meaning of ampicillin, sulbactam, amoxicillin, clavulanic acid.
Amoxicillin sulbactam.
Amoxicillin sulbactam. Amoxicillin sulbactam. Your favorite. And piperacillin, tazobactam. Ticarcillin, I'm not sure what combination it comes with. Similarly, the next group I am going to tell is carbapenems, meropenem weberbactam, like that many new things are coming. Ceftazidime avibactam. Okay. Right? So first point about extended spectrum penicillin is they covers gram-negative bacillus, so it can be given for intra-abdominal infections and UTI additionally. But the main problem is they are beta-lactamase sensitive. So rather than giving ampicillin, amoxicillin, piperacillin alone, we are giving it as beta-lactam, beta-lactamase inhibitor in these combinations. So whenever you are writing antibiotic in this group, preferably write a combination: ampicillin, amoxiclavulanic acid, piptas, right? So this is one problem associated with
meropenem and ceftazidime.
Rather than simply writing ampicillin, amoxicillin, you can write this combination. This is meropenem weberbactam.
Okay.
Ceftazidime avibactam. I don't know whether meropenem aerobacter is available in India. It's even in Arizona.
Okay.
So this is one
So
problem
ampy,
associated with
amoxicillin and all is the beta lactam, and then we have the beta lactamase inhibitor combined.
inhibitor. Yeah. Now, even though it covers E. coli, Salmonella, Shigella, Proteus, this group does not cover Pseudomonas. So not
Oh.
all penicillins which I told now covers Pseudomonas, but piperacillin covers.
Only
Now,
piptas out of this.
Understand the reason? Only piptas. Yeah, ampicillin, amoxicillin does not cover Pseudomonas, but among these piptas covers. So which is the best drug now among these three, these four? Piptas, obviously, because piptas covers UTI, it covers intra-abdominal infections, plus it can cover Pseudomonas infection also. So it is more effective. So in gram-negative sick patients, piptas becomes the first choice.
In
One
addition
small
to
exception
all
is there, I'll tell it later.
in addition to all what penicillin also covers.
Also
I mean, the normal penicillin.
Now, yeah. Now tell me, can piptas be used for respiratory infection?
Yes, it can.
Yeah, because it is the basic spectrum as penicillin. So piptas covers lung also. In addition, it covers abdomen.
Yes.
So next time there should not be any question whether piptas can be given for lung. Piptas can be given for lung.
It can.
It can. Okay. So this finishes penicillin. Okay, so understand about penicillin, then about methicillin group of penicillin, then about extended spectrum penicillin. What comes after penicillin? Cephalosporin.
Yes.
I don't know how many generations are there now because a separate class was there. Name some first generation cephalosporins.
Hey, buddy, this is our talk. First generation is cephalexin. Then
I'm just writing what are very clinically used.
Yeah.
Second generation is cefuroxime, cefuroxime acetyl, cefixime, clinically used. Third generation you must remember. Most of the things are okay. Third generation is our favorite. Ceftriaxone. Zone next comes taxine, cefotaxime, cefoperazone, ceftazidime. Okay. Fourth generation is cefepime. I remember only one. Next comes that fifth generation, ceftabiprole. Like that, many are there, but practically we use this one. Then cefazolin I haven't used. Ceflexin. Okay, so what's the basic spectrum of this first generation, second generation, and third generation? First generation is like the basic penicillin. So gram positives mainly. Okay, gram positive basically. Few gram negative copy plus anodes. So penicillin equal to first generation cephalosporin plus it covers some gram negative, but it is more effective against gram positive. So in short, first generation gram positive. So the same spectrum as penicillin only. The thing is, ceflexin is not penicillinase sensitive. That means what? It can be given for skin and soft tissue infection. That is the indication. The only place where ceflexin is used now is same as penicillin, mainly gram positive infections. Classically, it is used for surgical prophylaxis and skin and soft tissue infection orally. Next comes second generation. Second generation is the same. Preferably gram positive it covers. Plus, you'll be shocked if you know the organisms. Moraxella, Klebsiella, atypical organisms. So Moraxella, Klebsiella, atypical organisms, gram positive. What syndrome it can be used? Lung infection.
Lung infection.
Correct.
Yeah.
So second generation, the clinical use, cefuroxime, cefuroxime acetyl, it covers gram-positive, it covers some gram-negative, mainly in an equal proportion. So it can be used in all syndromes where these can occur. So the same thing like penicillin only. But practically, where it is more used is lung infection, because most of the organisms of lung infection is covered by
The 1
skin
minute,
wound.
1 minute. First generation is not penicillin sensitive, no.
Penicillin
That
is
I
sensitive only.
clearly understand that. You have written not penicillin is sensitive.
That is, it is, no, what I meant was it is not destroyed by penicillin.
So it is useful.
It is useful in skin and soft tissue.
Okay.
Now understood. It is not destroyed by penicillin produced by organisms. So
Okay.
it has more action against staph aureus.
Okay.
Okay. Now come to ceftriaxone. Ceftriaxone is an equivalent to penicillin. Okay, so we'll discuss this ceftriaxone alone separately. So since I told you it covers same spectrum as that of penicillin, no, gram positive coffee. At the same thing, same story only I'm repeating. Gram positive coffee, gram negative coffee, gram positive bacilli, gram negative bacilli. Correct? Ceftriaxone,
Yeah.
third generation covers more of gram negative also, plus some anaerobes and spirochetes. Now tell me
It's like
the syndrome.
basic penicillin, alle.
Like basic penicillin,
Yeah.
plus it covers gram negative bacilli.
Gram negative bacilli.
Gram negative bacilli.
That is,
But I told you ceftriaxone does not cover listeria.
Yeah.
It does not cover listeria. Remember, intrinsic resistant.
It is like extended spectrum penicillin.
Yeah, it is like extended spectrum penicillin. Now tell me, what are the syndromes it can be used? Can it be used for skin and soft tissue infection?
Yes.
It can be used, but it is not preferred. It covers, definitely it covers, but it is not preferred because it has more potency against gram-negative organisms than gram-positive. So if you have to give for a skin and soft tissue infection among this list, preferably use first generation cephalosporin or a second generation cephalosporin. Third generation, does it cover skin and soft tissue? Definitely it covers. If you are giving ceftriaxone, it can cover staph or a strep cellulitis, but it is not that much preferred because it has less potency against that. Okay. Next, does it cover respiratory tract infection?
Yes.
It covers. Yes. Next comes what? Pneumococcus. Pneumococcus, it covers meningitis. Correct?
Meningitis.
Like
Yes.
penicillin, this covers meningitis.
Meningitis.
Gram-negative
meningococcus, gonorrhea.
So if you read some books, they'll tell single dose ceftriaxone is a drug of choice for pelvic inflammatory disease.
Pelvic inflammation, yeah.
Even for diphtheria, tetanus also you can use. But it is not the drug of choice because I told you, penicillin is used there.
Okay.
Right? Gram-negative best. So UTA, can it be used? Definitely.
Yep.
Diarrhea, can it be used? Definitely.
Yes.
Peritonitis, can it be used?
Yes.
Spirochetes, syphilis, it can be used. Leptospira. You know leptospira, the drug of choice is?
Ceftriaxone. Yes. Okay.
Only thing is listeria is not covered. Listeria is covered by ampicillin.
Okay. Nice.
Right? This is how you think and write. Now cefotaxime, same thing. Correct. Cefotaxime is the same group. It can be used for the same thing. But why ceftriaxone is preferred and cefotaxime is not is based only entirely on the pharmacokinetic properties. Okay. Now ceftriaxone and cefotaxime does not cover pseudomonas. So if we need a pseudomonas, ceftazidime is there. As per older books, cefoperazone also covers pseudomonas. So I gave you one insight. No, ceftaz among penicillin group covers pseudomonas. Among cephalosporin, ceftazidime. ceftazidime is used with avibactam, right? So ceftazidime avibactam or ceftazidime, and cefoperazone with sulbactam.
Okay.
So this cephalosporin beta lactamase combination can cover Pseudomonas. Newer edition says that cefoperazone sulbactam does not cover Pseudomonas, and Harrison says that only ceftazidime is the third generation cephalosporin which covers Pseudomonas. But as per older books and practical experience, we still give for cefoperazone sulbactam as of now.
Okay.
Right?
We don't have
With this,
ceftazidime avibactam combination in our hospital, do we?
I don't think so. Ceftazidime alone is
Have
available.
it? Yeah.
Ceftazidime is available. Ceftazidime is preferred by nephrologists.
Yeah.
I'm negative.
Thank you.
Okay.
Okay. Now, once cephalosporin is completed, what is the next group? Meropenem, carbapenems.
Yeah.
So among carbapenems, what we have? Meropenem is the favorite one. Imipenem is there. Ertapenem. Carbapenems, the same thing. The same spectrum as penicillin plus Pseudomonas plus Listeria plus some extra anaerobes. So as the spectrum increases, it covers more and more anaerobes, more and more Listeria, more and more Pseudomonas. That's it. So ceftriaxone doesn't cover Pseudomonas, Pseudomonas and Listeria, whereas carbapenem covers. Okay, they say ertapenem is the only thing which doesn't cover Pseudomonas, but practically we use meropenem and imipenem, so the same thing. So nearly piptaz and meropenem are the same, right? Because piptaz also covers the same thing, meropenem also covers the same thing, but which is the best one? Piptaz versus meropenem. Now we'll just discuss three differences.
Actually, no.
Piptaz versus meropenem.
Meropenem covers Listeria. No. So in meningitis patients more than 65 years, we can give
Meropenem can be.
Yes,
Meropenem can
rather than ceftriaxone plus ampicillin.
But usually we give as a first choice ceftriaxone. Meropenem definitely can be used. Okay. Ampis, amoxi, ampi, ceftree versus three important differences which you should remember.
Okay. 1 second.
One trial was conducted. That's called the Merino trial. As per Merino trial, if beta-lactamase inhibitor is resistant, we can give meropenem. So practically meropenem is more powerful than piptaz. Okay, as per trials.
Once
So
more,
if you
can you
are having
repeat
a pyelonephritis, as per Merino trial, if beta-lactamase inhibitor fails, because I told you piptaz and meropenem nearly have the same spectrum, but which is better among the two? As per trials, they tell if piptaz fails, give meropenem. So meropenem is a bit powerful drug than piptaz, even though the spectrum is same.
So what have you written there? BL, BLI? If it fails, you give meropenem. Okay.
Yeah, if it fails to act, give meropenem. So meropenem is powerful than piptaz as per Merino trial. Amoxi and ampi. Amoxi is oral. Ampi is only IV. Ampicillin causes more of diarrhea. Amoxi causes less of diarrhea.
But the ampicillin is available as a combination of in oral.
Sorry?
The ampicillin is available as oral form in combination.
Yeah, it is available. IV oral. Amoxi is only oral. Ceftriaxone and cefotaxime, one important difference is there. Ceftriaxone is mainly metabolized in the liver. Cefotaxime is mainly metabolized in the kidney. So when I was UG student, I was taught like this. Patients with more of liver failure give cefotaxime. Because if you give ceftriaxone, the liver cannot manage ceftriaxone. So in patients with liver failure, give ceftriaxone. In patients with renal failure, give ceftriaxone. Okay, this is what I was taught. But naturally, another question comes. Leptospirosis, the drug of choice is ceftriaxone. But leptospirosis affects the liver, correct? Hepatitis, anectic hepatitis. Why so? So even though if there is hepatitis due to leptospirosis, drug of choice is ceftriaxone. The reason is only then ceftriaxone can get concentrated in the liver and kill the bacteria. That is the reason. But practically,
so ceftriaxone metabolism is by the liver.
Mainly in the liver.
Mainly in the liver. So you give in renal failure.
Yeah. So in liver failure, it has to be preferably avoided, except in case of leptospirosis, where in spite of failure, we can. Okay. Clear with this?
Yep.
So if you understand this scenario, in another 15 minutes, we'll finish all the other antibiotics, right? So penicillin spectrum is gram-positive cocci, gram-negative cocci, gram-positive bacillus, pyroketes, and some anaerobes. It acts less against Staph aureus because of penicillinase production. So it can be used for all these syndromes. Yes, except Staph aureus infections. So mainly it is used for rheumatic fever, syphilis, diphtheria, and tetanus. Now to make it more effective against Staph aureus skin infections and bone and joint infections, they created another group called as methicillin group. Methicillin, oxacillin, cloxacillin, which are given for skin and soft tissue infections because it covers MSSA. So till now we have finished MSSA cover. So among penicillins, oxacillin, cloxacillin group is good for MSSA. First generation cephalosporin, cefalexin is good for MSSA, skin and soft tissue infection and bone and joint infections. Next comes extended spectrum penicillin. We have aminopenicillins in the form of ampicillin and amoxicillin, uridopenicillin in the form of piperacillin and ticarcillin. These are sensitive to beta-lactamase produced by organisms. So we give it as a combination with ampicillin sulbactam, amoxicillin clavulanic acid, piperacillin tazobactam. This becomes BL-BLI, beta-lactam, beta-lactamase inhibitor. So the spectrum is same, plus it covers gram-negative bacillus. So for practically any infections, this can be given. Okay. Next comes cephalosporin, same thing. First generation cephalosporin is cefalexin and cefazolin, given for skin and soft tissue infection. Second generation, the spectrum is more towards a respiratory spectrum. So cefuroxime, cefuroxime are given for lung infection. Third generation, we have ceftriaxone and cefotaxime, which is similar to that of extended spectrum penicillin, except listeria. So practically, again, the same thing. Any infection, ceftriaxone is the first choice now, mostly. The anti-pseudomonal third generation cephalosporins are cefpoperazone and ceftriaxone. And coming to carbapenem, we have imipenem and meropenem. Ictas and meropenem have nearly the same spectrum, including anti-pseudomonal activity. Forgot to mention that. Carbapenems have anti-pseudomonal.
Yeah, but so ceftriaxone we can give in renal failure. No?
Yeah.
Yeah. Yeah.
Cefotaxime in liver failure.
Liver failure.
Cefotaxime we can give in liver failure because it is metabolized in the kidney.
Metabolized in kidney.
Yeah.
Cefoperazone is metabolized in kidney, so avoid in renal failure, but can give in liver failure. Difference between imipenem and meropenem is imipenem causes seizures, meropenem does not cause seizures. So remember these four differences. Okay, so understood till now. This is the major group of antibiotics very commonly used. If you understand, meropenem does not cause seizures.
No seizures.
That's why it is used in meningitis. So imipenem is not used in meningitis because it can cause seizures. It can be used in other infections.
Sir, one more doubt. Actually, there's not a difference between piptas and meropenem. No. If only piptas is not
no difference. No difference. If piptas is not working, we have to go for
meropenem.
That is why they said based on many trials, meropenem was found to be better.
Yeah. Okay. Now another one small difference. This I learned 2 days back in a conference, CMC Mac conference. Meropenem or Piptazilla. They compared Piptaz with 7% sulfate. See, I told you Piptaz covers all organisms, including Pseudomonas. Okay, that is why I told you for bloodstream infections, hospital-acquired infections, Piptaz is a very good choice. But what they are telling is in Indian setup, 7% sulbactam is a better drug than Piptaz in Indian setup. Because Piptaz some resistance is growing in. So Piptaz versus Meropenem, which is the best drug? Meropenem. Piptaz versus 7% sulbactam, which is the best drug? It is 7% sulbactam. Just a small difference. Some resistance to Piptaz is noted, it seems, in Indian subcontinent.
Everybody started Piptaz.
Piptaz is still the best drug in foreign. Yeah, maybe that's the reason. This year, just 2 days back, I heard in a conference, conference.
So actually, both have the same cover, Piptaz and
yeah, nearly the same. Third generation,
nearly the same.
Same spectrum.
Only doubtful thing is
the same as
whether cephalosporin sulbactam has coverage for Pseudomonas. That's the only doubtful thing.
That's the only doubt.
Other than that, otherwise it's almost the same.
It is a good drug.
And in Indian subcontinent, we
prefer 7% sulbactam. If you have to go according to Harrison says 7% sulbactam doesn't cover Pseudomonas.
Yeah.
Actually, Piptaz we are using for so many years now, but sulbactam we are started using recently only, no?
Recently only. Maybe that is the reason.
Yeah, actually true, I think.
And we have seen 7% sulbactam is. I usually use 7% sulbactam. It's a good drug only. Good response. Maybe this is the reason. We don't know. Okay. So this finishes one major group. Now with the same technique, we are going to rapidly finish the other small groups of antibiotics. Okay. Macrolides. Name 2 macrolides which we commonly use.
Azithromycin, clarithromycin.
Azithromycin, clarithromycin.
Differences. Spectrum. Gram positive. Okay. Gram positive means all gram positive. So gram positive cocktail, gram positive bacilli. Some anaerobes. Atypical. So whenever they tell azithromycin, name should come as atypical. So atypical plus gram positive cocktail. So what spectrum it can be used?
Respiratory tract infection.
That's why azithromycin is used. So if you think about the protocol of management of pneumonia or lower respiratory tract infections, this is what the Indian guidelines. There are 5 categories. Category 1 is OP patient. So you know how to categorize the patient based on the curve 65 score. Curve 65 score is 0 or 1. Patient is treated as OP. So OP patient without any comorbids. Next is OP patient with comorbids. So OP patient without comorbids, only one oral antibiotic is needed. The one oral antibiotic may be amoxicillin or macrolide, because both are the same. No, amoxicillin also I told you what it's an extended spectrum penicillin. It covers the respiratory spectrum. Macrolide covers respiratory spectrum in addition to atypical organisms. So any one among these things you have to use.
So, but the thing
is, patient with the comorbidities.
But does the amoxicillin cover atypical also?
No, it doesn't cover atypical.
It doesn't cover. So ideally, we should give both.
It doesn't cover. Ideally, we can give one as per guidelines. But if you give macrolides, it is better choice than amoxicillin because it covers atypical also. So azithro versus amoxicillin, azithro will be better. But if you are very sure that patient is having only a bacterial infection, radiologically you can differentiate. Now, for example, patient is having a consolidation, amoxicillin because it's a typical organism. Patient is having a bilateral involvement with bronchitis-like picture, use a macrolide. That is how you differ. If you are not able to do an X-ray, preferably give. Typical organisms, no. the Streptococcus pneumoniae, Moraxella, and Haemophilus, they cause consolidation, lobar pneumonia. So if there's a unilateral involvement, one lobe is getting involved, it is, you can think radiologically as it is a typical organism. Whereas atypical organisms usually cause interstitial pneumonia, a bronchopneumonia pattern, a diffuse interstitial pattern, and bilateral involvement. So if there's a bilateral involvement with the lower respiratory tract infection, the possible organism will be an atypical organism, preferably use a macrolide. Whereas if there's a consolidation, lobar pneumonia pattern, think of a typical organism, amoxiclav is preferred.
Yeah.
Just a clinical approach. That's but if the patient is having OPE patient with comorbidities, definitely both the antibiotics.
Both we can.
No confusion.
Okay.
Amoxiclav plus macrolide. Suppose macrolide is not available, we have to use doxycycline.
Oh,
okay. Now comes the third category. IP patient. IP patient is one.
Can you wait for 30 seconds? Just complete writing.
You are getting the flow of the lecture now. You are understanding now.
Yeah. Excellent lecture. Okay, I'm done. For those
now.
Yes,
I'm done.
On man.
So IP patient means what? Curve 60 score is 2.
2.
One IV antibiotic plus one IV antibiotic plus one oral antibiotic. So oral antibiotic has to be azithromycin, definitely. Plus the IV antibiotic, what I told you, ceftriaxone. Guidelines say ceftriaxone. Can you use cefuroxime? Yeah, correct. Second generation cephalosporin can be cefuroxime acetyl or cefuroxime.
Ceftriaxone plus cefuroxime plus
no.
Ceftriaxone plus azithromycin. In place of ceftriaxone, you can use cefuroxime also.
Okay.
Now here comes the main confusion. ICU patient. Patient is an IP also. It is we are giving one IV antibiotic, which is a cephalosporin or a penicillin group, plus one macrolide group. Same like OP, but one is IV, one is OP, oral. Main confusion is when the patient is in ICU, what drug to give. Please remember that when the patient is in ICU, we have to give 3 antibiotics. All has to be oral. We have to give 2 drugs which cover pseudomonas.
All has to be oral.
IV.
You
mean? IV. 3 drugs should be IV. 2 drugs have to be anti-pseudomonal. 1 drug has to be MRSA.
Okay.
You can change the protocol empirically if you know what are the risk factors for pseudomonas. Now tell me what are the risk factors for pseudomonas.
Age more than
whom do you suspect pseudomonas?
Age more than 65.
What you tell, I will write.
Pre-existing
lung diseases.
Comorbid conditions. The previous infection with pseudomonas.
Previous hospitalization less than 90 days.
Previous hospitalization.
It need not be previous infection. Previous hospitalization less than 90 days itself is a risk factor for pseudomonas. So pre-existing lung diseases means what? Cystic fibrosis, bronchiectasis. This you know practically. Any bronchiectasis, pseudomonas.
Yeah.
Any cystic fibrosis, pseudomonas. Any cavity, pseudomonas. So any pre-existing lung disease, it's invariably cavity. Invariably pseudomonas. Plus, you can add other comorbids also: chronic lung disease, chronic smoker, chronic heart disease, etc. Risk factors for MRSA. How does Staph aureus come? That's all. IV drug abuse, catheterized patient, that is central line. Catheter, I mean central line, or dialysis catheter patient. That is why pneumonia in a renal patient we give cover for MRSA, right?
Oh.
You understood this. ICU patient, by guideline, you have to give 2 drugs to cover Pseudomonas and 1 drug to cover MRSA empirical. But assess the risk. If the patient is at high risk of MRSA, give MRSA cover more. If the patient is at high risk of only Pseudomonas, give Pseudomonas cover alone. So what antibiotics you can give?
Okay.
So what they tell is, two drugs for Pseudomonas is must. So 2 drugs to cover Pseudomonas is must. This 1 drug to cover MRSA is your option. So patient is in a central line, we must give a MRSA cover. Patient is not in a central line, having these comorbidities, we have to give 2 anti-pseudomonal drugs. Now tell me what are anti-pseudomonal drugs from the above list. The list is incomplete.
Just shall we start the anti-pseudomonal the next thing? It will get over now.
Time, how many minutes more?
1 minute and 30 seconds.
We'll finish this here. So
we'll finish.
Anti-pseudomonal is piptas, we already discussed. Ceftazidime, avibactam we have discussed. Cefoperazone, sulbactam is discussed. Carbapenems except ertapenem I told you. Now add this along. Aminoglycosides and respiratory fluoroquinolones. The respiratory fluoroquinolones are levofloxacin and moxifloxacin.
Okay.
That's all. Okay. We'll close and we'll start the next session.
The aminoglycoside especially levofloxacin and moxifloxacin.
Moxifloxacin.
But carbapenem except ertapenem,
ertapenem.
Yeah.
So we have to actually in this, if you look like that, piptas plus mucus.
Yeah. So piptas plus aminoglycoside. Okay. Meropenem plus levofloxacin. Cefoperazone, sulbactam plus aminoglycoside.
That is the crazy.
Piptas plus carbapenem don't give because they are same action, no?
Yeah.
These drugs are same action.
Piptas plus moxiflox.
Right? So one among the top 4 plus one among the bottom 2. Okay, shall we close and start?
So can you also suggest the combinations you would prefer? Anti-pseudomonal combination.
Thing is, all pneumonia guidelines in the world say that the first choice drug for pneumonia is fluoroquinolones. But in India, we don't use that because you know the reason TB is very common. These two are second line drugs for TB. So if TB is ruled out, fluoroquinolone is actually a best drug. But in our setup, in government setup, since both are not available, we give piptas plus aminoglycoside. So it depends on the choice only. If you are in private setup, if TB can be ruled out confidently, then I think respiratory fluoroquinolone is the best drug because it is an internationally accredited drug, internationally proven drug for pneumonia is fluoroquinolones only. So I think piptas or a meropenem plus fluoroquinolone will be the best choice. But if you are not able to prove infection, aminoglycosides. That's why now most of the prescriptions contain moxifloxacin or levofloxacin. Right? So ICU patient, that should be 2 covered. This is the final take-home message. Now come to MRSA.
Levoflox is 500, right?
Yeah.
500 mg OD. Moxi is 400. Huh?
Moxi also 500. Based on weight, actually 750 also can be given. 750 BD also can be given for Moxi and Levo.
Okay. Yeah, 750
based on weight. Okay. Now, just a small revision. Drugs for MSSA.
Drugs. It is methicillin, cloxacillin, dicloxacillin, etc.
Then Cephalosporin, first generation cephalosporin.
Oh, first generation cephalosporin. Yeah.
Okay. Now just note down the other drugs also. Doxycycline can come. So doxycycline can also be given for cellulitis. Yeah. This is even new to me because it's given in Addison. Recently, when I read only, I found out. Similarly, cotrimoxazole.
Okay.
So these can be given for cellulitis. That is, these cover cellulitis, not the drug of choice for cellulitis. Okay.
Okay.
Okay. What are the drugs for MRSA? Another table. At least remember two.
Vancomycin, linezolid. Yeah.
If vancomycin is resistant, we go to linezolid.
But yesterday for that patient, we started linezolid, right?
Yeah. Because if vancomycin resistance is there, linezolid is the best drug. So empirical linezolid is better than vancomycin. That reasonably.
But
so Piptas
but should we keep linezolid?
Okay. As a reserve.
Yeah, as a reserve.
Maybe not now, because linezolid resistance has not been reported till now.
Okay.
So as of now, you can use it.
Okay.
Next is daptomycin. Cunapristin, dalfopristin. This is just for theoretical sake because we don't use this much. We restrict to these two things. At least no vancomycin, linezolid.
Vancomycin dose? Any idea?
1 gram IV TDS, but based on the renal clearance. If the renal clearance is low, 1 gram BD, or sometimes 1 gram every alternate days also we give based on the GFR. Some formulae are available. Linezolid dose is simple, 100, 600 milligram BD. Okay, cunapristin, dalfopristin. Okay, why we started is we started about the discussion of azithromycin and clarithromycin.
Yeah.
Erythromycin. Yeah. Nothing. So macrolides they cover mainly gram positive. It is a replacement to penicillin, especially for gram positive. Which is the best among these three? I feel azithromycin because it is better tolerated than the other two. It's given for a short course, only 3 days. Less drug interaction. So 500 milligram OD for 3 days is the practical dose which we give. But textbook says 500 milligram stat followed by 250 milligram OD for 4 days. So anyway, the total dose for azithromycin is 1500 milligram. That's all. Clarithromycin, 500 milligram BD is given till resolution. But I don't prefer clarithromycin because it has so many drug interactions. That's an MCQ question. Which are the drugs which are mostly interfered? Warfarin is interfered. Statins are interfered. Tacrolimus is interfered. The patient taking these drugs, if we give clarithromycin, we can predict the toxicity, how it goes. The patient not taking this, clarithromycin is good. But otherwise, azithromycin is a fairly good drug.
Dose of clarithromycin was 500 BD.
500 BD for usually 7 to 10 days.
And this QT prolongation more with the clarithromycin.
More with azithromycin.
Azithromycin. Okay.
Okay. So two classes over. Now tell another class of drug. Hereafter you are only going to tell. I finished the majority.
Another class of drugs is aminoglycoside. Okay, toxic.
Okay, we'll give aminoglycoside. Aminoglycosides and fluoroquinolones, if you speak, entirely gram negative. Okay.
Okay.
Except respiratory fluoroquinolones, levofloxacin and moxifloxacin, the respiratory fluoroquinolones because they cover gram positive. Okay, that's all.
Okay.
So gram negative means you know what are the spectrum which is covered by aminoglycosides now. UTI.
Just a second. What did you ask again? Which is the?
So aminoglycosides covers gram-negative infections.
Okay.
And anaerobes. So what are the spectrum it covers? UTI, diarrhea, peritonitis, and it is anti-pseudomonas. That is the most important advantage.
Yes.
Usually, whenever there's a resistance, whenever there's a pseudomonas resistant piptas or something, we always think about going to the next stage, like giving colistin or some drug. But recent trend is go behind. Aminoglycoside is a simple antibiotic, but all pseudomonas is inherently sensitive to aminoglycoside. Aminoglycoside resistant pseudomonas has not yet been reported. So if there is piptas resistant to pseudomonas and we don't have any other sensitivity, we can try giving aminoglycoside. Go one step behind. Similarly, we can try giving fluoroquinolone one step behind. It's a simple option than giving colistin. Again, recent studies have shown that giving colistin for pseudomonas resistance carries 40% mortality, whereas giving alternative drugs has only 13% mortality. So don't think about giving colistin. Think about giving aminoglycoside or fluoroquinolone for pseudomonas resistance. Right? And we have discussed one fact already. What? The combination, no? We can give penicillin along with aminoglycoside combination. Penicillin
I didn't get that.
breaks
Can you
the cell
repeat,
wall.
please? Can you
Which one?
repeat, please? That point, last
That
point.
pseudomonas.
Regarding penicillin.
Pseudomonas point. Penicillin is given along with aminoglycosides. Penicillin, what does it do is it breaks the cell wall. That is its action. After it breaks down, aminoglycoside can penetrate the bacteria and it can reduce the protein synthesis. So double action. Usually this combination is used in infective endocarditis and meningitis in children. Previously, meningitis, they used to give ampicillin and gentamicin only. Now that combination is restricted in adults to infective endocarditis. Okay. Okay, then nothing much about fluoroquinolone, I think. We have discussed the points already. Sulfonamides. Sulfonamides, the only practical sulfonamide in use is one is dapsone. We are not going to discuss that. It's an anti-leprosy drug. The other one is cipran.
Oh, yeah.
He told no, cotrimoxazole, it covers MS6A. It is also predominantly gram-negative. It covers some anaerobes. So, since gram-negative, the same thing. UTI can be used. Diarrhea can be used. So, one choice for UTI is we can give aminoglycosides, we can give fluoroquinolones, we can give sulfonamides. Correct?
Aminoglycosides.
Theoretically,
what did you say?
Fluoroquinolones, aminoglycosides,
and sulfonamides.
Most important drugs you forgot: nitrofurantoin, phosphomycin. Yeah, they are also used for UTI only, no?
Yeah.
Can nitrofurantoin be used for pyelonephritis?
No.
Resistant.
Because nitrofurantoin gets concentrated in the bladder. So it can be used only for cystitis. So if the patient is having a pyelonephritis as the infection syndrome, the urine culture grows E. coli sensitive to nitrofurantoin. Don't give nitrofurantoin because it is not going to act on the kidney. It is going to act only in the bladder. That is only going to act on nitrofurantoin. They give it as chronic clearance. Bladder. So only in cystitis it will act. Post pyelonephritis you can give to clear the bladder, but it doesn't act on the kidney. Okay. Phosphomycin, I think you know the dose.
Yeah.
So I think we have covered the majority, right?
Yeah.
Now, the main point which I want to stress is next time, whenever you are seeing an infection syndrome, your thinking should be going in this pattern. Think of all the possible organisms. Think of what all the antibiotics can act. And among that, you have a preference. This will be the first choice. This will be the second choice. Based on the patient, you are going to decide and give. Correct?
Okay.
I think, did that approach come to you to some extent?
Yeah, we need to revise this again. Practice it.
Yeah. We are going to practice this now in the next 15 minutes.
Okay, that is good. That is what we want.
So we can.
So before going into the practice, we are going to practice it based on the guidelines. Stop the recorder. No, this also has to be recorded. New guidelines.
New guidelines.
Tell the thing, we'll just new guidelines. That only we are going to discuss. So summarizing till now, I told you about the various organisms, the infection syndromes they cause, the common antibiotics which we use, and what organism it covers, what spectrum it covers, and how all to practically give that we discussed, right? Okay. Able to see?
Yes.
Able to see this now. So this is the actual 2020 new guidelines published by ICMR. So I was telling you about this one, the rational use of antibiotics, antimicrobial stewardship. So these are the 5 steps of antimicrobial stewardship, which was your essay question. First thing is make a clinical diagnosis. Question is it an infection or not? Okay, because all fever is not infection. It could be a drug-induced fever also. So is the fever an infection? That is the first question. If it is an infection, try to limit to empirical antibiotic therapy. Remember, I was telling you 4 or 5 indications where you must give empirical antibiotics. These are the conditions. Okay, febrile neutropenia, sepsis and septic shock, community-acquired pneumonia, ventilator-associated pneumonia, necrotising fasciitis. I would preferably add a meningitis also in this case. Okay, so UTI can wait, a diarrhea can wait without antibiotics. But these conditions, we must start empirical antibiotics. So confirm infection, try starting antibiotics. Whenever you have to start antibiotic, classify the infection syndrome. See, this is what I was telling you. Identify the clinical syndrome, try to identify the possible source of infection, predict the possible microbial pathogens, know the resistant pattern and write them. Then choose the appropriate antibiotic, optimize the PK/PD parameters, try to reduce the duration of therapy, right? Acute fever, I'm not going to discuss. It's about dengue fever, those things. Sepsis also we are not going to discuss. We'll come to that last. Okay. LRTA. Sorry, pneumonia. Okay. Before I open, just tell me, how will you treat pneumonia? What are antibiotics you can give for pneumonia? That's what I was telling, right? Outpatients without comorbidities, one drug. Preferred drug is coamoxiclav. Okay. Because I told you, it covers the typical organisms. Alternative is macrolide, cefuroxime. This also we have discussed, right? Macrolides cover atypical organisms and the gram-positive organisms. Cefuroxime is a second generation cephalosporin which can be used the same reason. But in India, compared to macrolides, doxycycline resistance is there, so we give macrolide. Okay. Next, outpatient with comorbidities, give both coamoxiclav plus macrolide or coamoxiclav plus doxycycline. Okay. Instead of coamoxiclav, we are giving cefuroxime also. This is clear, right?
Yeah.
Inpatient who is not in the ICU, I told you, one injectable drug plus one non-injectable drug. Same thing, ceftriaxone plus macrolide or doxycycline. In place of ceftriaxone, replacement. We can give cefotaxime, amoxiclav injection. This is clear, right? Because amoxiclav
also
we
usually follow here.
Same thing. So injection amoxiclav, augmentin.
Tablet.
Yeah. Inpatient ICU, I told you 2 pseudomonal. Actually, here they are classified into 2 other factors. Inpatient ICU without risk factors for pseudomonas and inpatient ICU with risk factors for pseudomonas. So ICU, if there is no risk factor for pseudomonas, they have retained with the same thing, zone plus macrolide. Okay. But risk factor for pseudomonas, they are given piptas plus macrolide or doxycycline. Okay. Then second choice they are given is imipenem.
Is it piptas plus macrolide or piptas bar macrolide? They have given just
actually,
one.
what I learned from other sources is 2 drugs. Actually, I had to give 2 drugs only.
Harrison says 2 drugs.
Which I told you. Yeah. Practically, we follow the same only. So 2 anti-pseudomonal drugs.
Okay.
So this is the risk factors for pseudomonas. Chronic respiratory disease like COPD, bronchiectasis, asthma, chronic bronchitis, neurological disease, enteral tube feeding, and immunocompromised people. Risk factors for community MRSA is preceding influenza, cavity, shock empyema, plus that IV drug abuse, central lines, etc. Okay. Just I'm going through this. So clear with this respiratory tract infection, no. So this is just a basic guideline, but practically you can change. Can you give seropresin sulbactam? Of course you can give if you are suspecting. You can give meropenem. You can give Piptas. You can give ampicillin. Everything can be given, but decide based on the patient. Okay, then skin and soft tissue. Cellulitis. I told you. Based on the guidelines, the best drug is amoxicillin clavulanic acid. Okay, or second generation cephalosporin, first generation cephalosporin, cefazolin or ceflex. Clindamycin, I forgot to tell you. Clindamycin, how it acts is, one important group we forgot to tell. Drugs for anaerobic infections.
Yeah.
Remember 2 drugs. One is metrozil. Second is clindamycin. Okay, metronidazole and clindamycin are the drugs for anaerobic infections. Okay. Clindamycin has 2 actions. Clindamycin has 2 actions. One, it acts against anaerobes, plus it inhibits toxin production from staphylococcus and streptococcus. So giving clindamycin in addition to any gram-positive toxin production from streptococcus and staphylococcus. You would have heard about the super toxin production, right?
Super antigen.
Super antigen that is produced by something. Super antigen is produced by gram-positive organisms. That is inhibited by clindamycin. So giving clindamycin in addition to gram-positive cover has a very good effect. So like in places where penicillin is given along with gentamicin, in skin infections where staph or strep infection is suspected, we can give that cover plus clindamycin. That is what is given. The amoxiclav plus clindamycin. Necrotizing fasciitis, the same thing. Clindamycin plus Piptas. Now you can ask why necrotizing fasciitis they are giving a Piptas cover rather than a preferably positive cover like clostridium. Because it is polymicrobial. The organisms are Streptococcus pyogenes, Staph aureus, anaerobes, and gram-negative. So if you are suspecting more of a gram-positive cover, like a plain cellulitis, it is enough to give cefazolin, ceflexin, or amoxiclav. Whereas necrotizing fasciitis is polymicrobial, give Piptas. Understood that. That's the only basic. Similarly, abscess also same. Plain abscess, amoxiclav plus clindamycin. They are given anyone, clindamycin or amoxiclav or ampicillin sulbactam. MRSA is suspected, vancomycin or lemzol.
So generally speaking, amoxiclav is a very good drug.
Yeah, amoxiclav is a very good drug for cellulitis. Individual choice, actually, it's a drug of choice. Bone and joint infection. It's not again. Bone and joint infection also the same thing only will come. Okay, they haven't mentioned the antibiotics specifically. Okay. But same thing only. Think of the gram-positive cover and treat it. Most of the bone and joint infections will be acquired through blood. So some organism may grow. But I told you bone and joint infection is not the immediate empirical. That is empirical antibiotic need not be started immediately as per the new list given. Okay, CNS infection, what is the drug? acute bacterial meningitis.
So it is basically caused by gram-positive cocci, and Haemophilus influenza is gram-negative as well, and gram-negative cocci.
Actually, this is the guideline which is given by India. Okay, ceftriaxone, 2 grams IVBD, acyclovir, artesunate plus doxycycline. This has to be started for any patient who is suspected with meningitis. Once there is yeah, why ceftriaxone 2 gram is ceftriaxone 2 grams IVBD will cover meningococcus. So in other infections, we have to use ceftriaxone 1 gram IVBD. But in suspected meningitis, especially meningococcal meningitis, the dose is 2 grams IVBD. So patient comes to you, they are suspecting meningitis, start a steroid plus ceftriaxone, acyclovir, artesunate, doxycycline. Why doxycycline? Leptospirosis, aseptic meningitis. Once your investigation start coming, you start coming to a diagnosis. If there's a bacterial meningitis, stop acyclovir. If malaria is ruled out, stop artesunate. If lepto is negative, stop doxycycline. Like that.
So all those patients are coming to Cori meningitis, we have to start artesunate.
In our setup now in Madras Medical College, we used to give. Here it is not given usually. We use because it is very common there. We used to give.
Yeah, based on the
local
circumstance. Local.
And what is the proven meningitis? What drug will give? Vancomycin plus ceftriaxone. If it is more than 50 years, listeria cover. Ampicillin plus ceftriaxone plus vancomycin.
Proven meningitis, vancomycin plus ceftriaxone.
Vancomycin plus ceftriaxone.
So and ampicillin we start only after the confirmation.
No, more than 50 years empirically you can start ampicillin because listeria is difficult to prove. Listeria will CSF picture of listeria will mimic like viral encephalitis only. So preferably in any 50 years above age, we can give a course of ampicillin. It is not problematic. It's not wrong.
Nothing will happen.
Yeah.
Okay.
Then UTI. UTI I told no, acute cystitis, nitrofurantoin, phosphomycin can be given. Then I told you amikacin, cotrimoxazole, and fluoroquinolones, ciprofloxacin, those things can be given. Pyelonephritis, we should not give nitrofurantoin because it does not act here. Piptas is the choice. I told no, if Piptas fails, you have to go to the next step, which is meropenem, as per Merino trial and amikacin. Prostatitis, I'll skip for now. You understood this, no? Cystitis, nitrofurantoin, phosphomycin, Septran, amikacin, fluoroquinolones. This is the choice. Pyelonephritis, Piptas is the choice. If it is not working, go to meropenem. Now, hospital-acquired infections. Just tell me, hospital-acquired infections, what you must give?
Hospital-acquired, we should give MRSA and
Here comes ventilator-associated pneumonia. I told you, all the hospital-acquired infections, it is Pseudomonas, gram-negative bacillus, MRSA. So, Piptas or Seroperosin Salvac, plus or minus amikacin. Why? 2 drugs for Pseudomonas, whatever they are given. Pneumonia. Plus alternative, Piptas fails, you have to go to meropenem. Ceftazidime avidan. That's what they are given. If everything fails, last option will be cholesterol. Clear. MRSA covers injection linezolid or vancomycin. Here they are given a levofloxacin 750 milligram every day may be used as an alternative amikacin as a second line anti-pseudomonal agent. So probably in India they keep levofloxacin second, but in other countries levofloxacin is the first choice. Right? This is the empirical therapy for HAP. Then pneumonia. Central line associated. Okay, that CLAPSI page is not opening. CLAPSI again, same thing only. Central line, I told you, we are inserting from outside. So you have to give vancomycin. Okay, that's all. Infective endocarditis, I'm not discussing. Carbapenem is resistant, I'm not discussing. So that's all. Class is over. Something you understood?
Of course.
Yes.
So summary is this only. At this end, you should know what syndrome, what organisms, what are the antibiotics can work. Based on the particular patient, you think what other things can be given. We'll try in different combinations. That's how experience comes. Because sometimes a drug may not be available. When you are working in a government setup, Piptas may not be available suddenly. We'll be having other combinations. So if a particular drug is working, you can try another combination. If patient is having resistance or failure or intolerance to one drug, you can try another combination. Or you can, in due course, you can practice different combinations for patients and try which is working. But few things you should never miss. For meningitis, there's a protocol. For pneumonia, there's a protocol. You should never change that protocol. So like that, you start practicing antibiotics. We'll discuss in future. So next time, whenever you are starting antibiotic, tell the syndrome, tell the organism, tell the drug. We'll start practicing one by one. Right?
Okay. So this meeting will end in 10 minutes.
Okay. Then we'll stop recording and we'll speak. Thank you.
Okay.
Okay. Thank you so much.
Thank you.
Thank you, sir.